welcome to today's clinical question time case study. Again, we're carrying on with our cardiovascular scheme, and today's video is going to be themed around MI, also known as myocardial infarction, and referred in layman's terms to a heart attack. So let's crack on. So you're in the middle of conducting a medicines use review, MUR, with 73-year-old Mr. MI. Use the following repeat ordering slip as a guide whilst taking his drug history as a cross-check. When prompted on how things are going, Mr. MI goes on to tell you he hit his 8-month milestone in his stop smoking group meetup last week. He tells you he found it hard giving up smoking when he had his heart attack and stent put in 13 months ago, but knew it had to be done. Identified the 2 drug therapy problems present. Now, let's take a quick look at the repeat slip and identify the medications he's taking and link that up with what he's told us. So we can see that Mr. MI has told us he had a heart attack and a stent put in. And he's taking a group of medications, an ACE inhibitor, a beta blocker, which is bisoprolol, a statin is atorvastatin, aspirin, which is his antiplatelet, clopidogrel, which is his antiplatelet, and sertraline, which is a specific type of antidepressant known as an SSRI. So that the patient may have had some mental health issues from the actual disease itself and having a heart attack or living with the aftermath of a heart attack. So it's just something we can put in the back of our mind. Now, those that, suffer a heart attack often have a percutaneous coronary intervention where they widen the arteries where the heart is and carry oxygen to the heart, and then put a stent in to help provide sufficient oxygen, and then they normally put on what's called a dual antiplatelet therapy afterwards. So let's list what drugs a patient that's discharged from hospital after a heart attack's normally on. So they're put on an ACE inhibitor, a beta blocker. So Mr. MI is also on a beta blocker. They're put on a high intensity statin. So atorvastatin 80 mg, high intensity and high dose. And they're also put on antiplatelets. And patients are often put on a dual antiplatelet therapy. This is also nicknamed DAPT sometimes. And one antiplatelet's usually stopped after 12 months in those that have had a stent put in because of the increased risk of bleeding and whether or not it may be advisable when you balance that up against the benefit of preventing another cardiovascular event or reinfarction. So we can see from the clues in the repeat slip that we've got the issues, so the number of issues that the patient's been given, so it's how many times they've been given it in the community. So we can see that they're meant to have 12 issues and then there's normally some sort of review, but in this case it may not be because we've actually been given the review date as March, but obviously we can never assume, and they've had 13 issues. So this is the 13th issue that they've been given, and that seems to marry up with how long ago that he had the heart attack and stent put in, which is 13 months ago. So if we look at that, that means that maybe the patient needs to have their dual antiplatelet therapy reviewed, because this may have just been the GP's review date and the patient might be due for a review, and they should have their antiplatelet looked at anyway, even if the review's not due. And this is based on data from the DAPT trial, the dual antiplatelet trial, because we can see there's 2 antiplatelets, and often they'll take clopidogrel off or the antiplatelet that's been married up with the aspirin and keep the patient on the aspirin lifelong. Now, this is where the sort of understanding of what a percutaneous coronary intervention exactly entails and the specifics of it. So first we need to look at the coronary arteries. And the coronary arteries, they basically take oxygen to the heart. And if there's insufficient oxygen or there's a clot blocking these arteries, then you may get a heart attack. And there's different classifications of heart attacks. So the most common one being an ST elevated myocardial infarction. And that's where on electrocardiograph, there seems to be this ST segment elevation. So there's an elevation in the ST segment. And you get other types of heart attacks, so like a non-STEMI, or patient could, have had past angina and then, that's gone on and they've had an MI. So if we zoom in on these coronary arteries, you normally have these fatty deposits that turn into what we call atherosclerotic plaques. So these fatty deposits that turn into atherosclerotic plaques, and obviously that's what gives the narrowing. Now, with a percutaneous coronary intervention, you have this balloon, and this balloon basically goes in, and sometimes it has like a metal meshwork around it. So you take this balloon, using contrast dye to help identify the best area in the coronary artery where it seems to be the arteries are narrowest because of the amount of fatty deposits and how much quantity of atherosclerotic plaque there is taking up the artery. You find that the balloon's then placed there, and then it's inflated, and then hopefully that will push back and squash the fatty deposits to increase blood flow. And so hopefully there will be sufficient blood flow in the actual artery because you've narrowed it so much. And then a lot of the time what they do now is there'll be like a metal mesh around the actual balloon, and when they inflate it, it sort of springs open and the balloon will be retracted, and this mesh like network will stay there, and hopefully it will keep it open, the artery, so in case it's harder for the fat to build up and quash the stent. So the amount of oxygen that stays in the coronary artery stays for longer in case any dietary lifestyle changes, so they might carry on eating fatty foods and so on, that it may narrow it again. So aspirin's often given to reduce the risk of a cardiovascular event lifelong, and then an additional antiplatelet's given alongside to reduce the risk of a thrombus or a clot building on the actual mesh network itself, so on this stent. And often they will give Clopidogrel to prevent this stent thrombosis, and after 12 months they'll get reviewed and they will normally stop it because of the risk of bleeding, and weighing that against the benefit of reducing the risk of another cardiovascular event and reducing mortality. So now we can see, if you can actually see from the DAP trial data, if you look it up yourself, and I'd advise that if you want any more knowledge, that after 12 months there was a little bit of data that was quite surreal, that there was the all-cause mortality when you carried it after 12 months, it usually predated from cancer in many of the patients. Now, it was believed that many of the participants of the data enrolled with predisposed risk factors to contract cancer or already had cancer. So that's what most clinicians believe, and so it's mainly the bleeding risk now. If you do take a look at the data, in case you're a bit weirded out by that. Now, some cardiologists, when they do review it, they may do it a bit longer than 12 months, and it all depends on other factors including the type of MI, so whether it's a non-STEMI, STEMI, whether they, the type of stent that they've had put in, so whether it's a paclitaxel or everolimus-based stent, and so forth. So, now aspirin and clopidogrel work by different mechanisms, and so that's actually good because you get a synergistic effect. So they sort of complement each other to reduce the risk of bleeding, and that means you can give lower doses than if they both had the same mechanism. So aspirin works to irreversibly inhibit what's known as the cyclooxygenase enzyme, and it blocks COX-1 and COX-2, which are two different types. COX-1's produced constitutively, and COX-2's produced normally in white blood cells and only in certain responses. And it actually acts to irreversibly inhibit COX-1 and COX-2 by acetylation. This actually reduces the production of certain pro-aggregation factors that are produced by the cyclooxygenase enzymes known as thromboxanes, so TXA2. And that's made from the upper precursor of arachidonic acid when it goes down through the pathway, and all in all that slows down this platelet aggregation, so you don't get a clot. Now the antiplatelet effect, it occurs at low doses, so normally 75 milligram, and it often occurs at the lifetime of the platelet. Because obviously remember, like, we're always turning over platelets, and these platelets, because they don't have a nucleus, to allow synthesis of new COX enzymes, that means that it will just occur for the whole span, and so only wears off as new platelets are made. Now, in contrast, you've got clopidogrel, which binds irreversibly to what's called adenosine diphosphate, and there's a certain pathway that uses this, and what happens is you have these ADP or adenosine diphosphate receptors found on the surface of platelets, and its ADP actually helps to mediate the activation of glycoprotein 2B3A, which are part and parcel of these receptors, and it forms a complex, and then that eventually goes to promote the aggregation of the platelets to get a clot. So obviously if you inhibit that, then you're not going to get that aggregation. Now, as you can see, this means that the most common side effect of antiplatelets is going to be bruising and bleeding. So unexplained bruising and bleeding, whether that's minor or major bleeding, are going to be the most common side effect. So, if someone cuts themselves, they may take a little bit longer to heal. Patients may get epistaxis, which is nosebleeds. So all types of bleeding. Now, the side effect of these antiplatelets, it has to be weighed up against the risk of a cardiovascular event, because patients that have suffered this, type of heart attack, they're at high risk of having another heart attack, or having another type of event. So normally, based on the DAP trial, as I referred to previously, the 12-month point, I'll write that down, is our review point. So we should really bring up with the clinician or the GP to trigger some sort of referral for a review for that patient's antiplatelet therapy, and then pass our concerns on. So the first drug therapy problem has been identified. Now let's move on to our second drug therapy problem. Let's look back at the question. So let's look up again at the screening of our repeat slip. Now, the actual problem that many of you might not actually see initially, is this to do with that SSRI? And it might be because I themed it cardiovascular, but this is to edge us into our next theme, but it's actually this SSRI. Now, SSRIs actually can cause gastric bleeding as a side effect, and the patient's actually on multiple medications that puts them at risk of bleeding, so they're elevated into a high risk category, and so that's something that we should be concerned about, because remember, they're on 2 other antiplatelets, so that means there's going to be a high bleeding risk. And on top of that, certain physiological and pharmacokinetic changes as you age puts this patient, because they're elderly, 73, at an even higher risk than someone that was younger and on these medications. Now, you might be thinking, well, how does, an SSRI cause bleeding? Well, let's take it from the beginning and look at some basic mechanisms. Now, platelets, they can't actually produce their own serotonin. So I'm making serotonin as 5-HT. It can't actually produce its own serotonin. So what does it do? It actually picks up serotonin from the plasma, and it actually reuptakes it through this serotonin transporter it has on its surface. Now, platelets, in order to promote and instigate aggregation, they may drop. So say, for example, there's an area of bleeding that's been identified, and the body's like, okay, the platelets, okay, we need other platelets to come and help aggregate. So what it will do to send that signal is it will drop serotonin 5-HT, and then that will sort of instigate platelet activation. So if you think about it, it's like, imagine someone's holding up a flag and everyone's like, oh my God, like we need to rush there, something's happening there. It's the same sort of thing. And then what the deal is, that will act as a platelet activator, and it will promote all this aggregation, and you'll get clot forming to help reduce the bleeding. Now, remember I referred to that 5-HT transporter. Now, what an SSRI does, a selective serotonin reuptake inhibitor, is it blocks this 5-HT transporter. Now, normally, as I said on the previous slide, it normally takes back up that serotonin, and then it will, use it again in case it needs to in the future, because it can't synthesize its own. Now, if an SSRI blocks the serotonin transporter, the platelet can't take up the serotonin from the plasma. So what does that mean? It means it can't sort of drop that flag. So it can't wave to other platelets to say, okay, come, you need to aggregate because there's bleeding happening here. So that stops that. So the patient's going to get bleeding. And in particular, gastric bleeding. So that's the most widely accepted mechanism. And some believe there's also another mechanism. So if we look at the stomach, some clinicians actually believe that SSRIs actually directly increase stomach acidity, and that can lead to a gap in the gastric lining or an ulcer. So if you know your anatomy, if we look, there's 4 main layers in the GI tract. So you've got the mucosa, the submucosa, the muscularis externa, and the serosa. Now, with an ulcer, there's a gap in that lining up until the submucosa. That's known as an ulcer. And so the cells are exposed to the acid, and a patient can get bleeding, and they can get, they can suffer peptic ulcer disease. And so that erosion, it puts the patient at risk, and we need to mitigate that risk. So what we should do is we should bring that up with the clinician or the GP and say the patient needs to be on a gastroprotective agent. because obviously the patient, if they do, need to be reviewed, then that's something that we should put in there also. Ideally, a proton pump inhibitor, so a PPI is given, because of the risk of bleeding. And just be careful, because certain proton pump inhibitors can interact with clopidogrel, but obviously it's all going to depend whether the patient stays on that or not. So that resolves our 2 drug therapy problems. Let's move on to the patient query portion. So second part, Mr. MI returns to see you the following week. He tells you he went to the local health shop to buy some garlic capsules since his friend told him it's good for the heart. However, the price was a bit steep and asks if you can do it at a cheaper price since he is a regular patient. Now, many patients seem to have this misnomer that if a medicine is natural, like a herbal remedy, it's practically safe. Now, garlic actually has an antiplatelet effect. So it actually acts on that ADP mediated pathway that we talked about earlier. And it uses that, it acts on that pathway to, again, inhibit platelet aggregation. And so that's why it's got an antiplatelet effect. Now, this is something that we should inform Mr. MI of. And even though he wants something that's good for his, heart, which is good because he wants to keep healthy, we want to avoid that risk of bleeding since he is already on other antiplatelets, and just reassure him of other non-pharmacological interventions, like, appropriate dietary and lifestyle interventions, and that this should help be adequate and good enough to help keep his heart in good health. Well, that wraps up today's clinical question time. I hope you found it useful. Please don't forget to like, subscribe and share, and I'll see you next time.